get going now. So today we're going to be talking about interventional oncology, which is a subset of interventional radiology and sort of how we care for patients with cancer in the IR space. And so IO, if there's any oncology interest group people, they're going to think that means immuno-oncology. We had it first so they can settle down. It's actually interventional oncology as opposed to immuno-oncology. So I'm just saying. So that's kind of what we're going to talk about today. And so we're going to talk a little bit about the definitions, some of the history, current therapies, and then sort of future directions for these kinds of treatments as this is all rapidly changing. So what is IO? Interventional oncology is the treatment of oncologic diseases with local therapies using image guidance. And so you're as minimally invasive as you can possibly be, but you're trying to treat them. And this is all out of the spirit of interventional radiology, which I'm a big fan of history, to be honest. So I like to talk about the history of stuff like this. And this is the event that sort of started interventional radiology. This is a guy named Werner Forsberg. And in the 1920s, they actually believed that if you put a catheter into a blood vessel, it would cause spasm and that the patient would die. And so Forsberg, who was a surgical intern in Germany, didn't believe this is true, or Forsman, sorry, not Forsberg, Forsman. And so he actually did a cut down on his brachial vein and actually put a catheter into his heart and then took an x-ray. And he did not die. And he did lose his medical license. He actually was, they barred him from practicing medicine in Germany, but he won the Nobel Prize for doing this. So I guess it's kind of a wash in terms of good versus bad. So, and he wrote a book eventually called Experiments on Myself. But the real operative thing that actually allowed us to become interventional radiologists as we are now was in 1953 with a paper written by Seldinger. And Seldinger decided that, okay, if I can put a needle into a blood vessel, I'll get blood back. Then I can pass a wire, then I can take the needle off, and then I can put a catheter on. And this is basically the basis for everything that we do in interventional radiology. And so it meant that you no longer had to do cut downs in order to do angiography. The first real angiography was done in the 1930s by a urologist, but he did it by cutting down on the arteries and then sewing catheters into the arteries. So it was quite invasive. So this actually was kind of a revolution and allowed the sort of beginning of, minimally invasive medicine, leading to this guy. And this is Crazy Charlie is what everybody who was his contemporaries called him. And basically in 1963, Laura Shaw, who was an 82-year-old diabetic, was told by her orthopedic surgeon he had to cut her foot off because she had gangrene. And she said, "You're not cutting my foot off." And so Charles' daughter actually angioplastied her superficial femoral artery, and it actually allowed it to heal. She died a couple of years later from pneumonia, but she healed from that acute event, and this was sort of the beginning. And he actually was on Life magazine for this. And the funny thing is they were using crazy things when you think about it now. The first guide wire was actually the speedometer cable for a VW Bug. That's what he used as a guide wire. He just kind of steamed it to make sure it was clean. And that's kind of what it was. And that's sort of led to this explosion in interventional radiology. So it was named in 1967, IR was, by a guy named Margulis, who was the most famous radiology chairman of all time at University of California, San Francisco. And basically it emphasized that these people who did this specialty needed to have specialized training, not just in imaging, but also in technical skills and clinical knowledge so that they can care for patients. And so he actually named the specialty interventional radiology. Charles' daughter hated the name, didn't like it at all, thought we should be some kind of permutation of surgery, but this is sort of, Margulis was a much more important radiologist than him, so he won. And the key was specialized training, technical skills, clinical knowledge, and ability to care for patients. So this was really, really sort of defines our specialty today. So if you look at IR, and this is the Wikipedia definition, by the way, it's a subspecialty of radiology, which uses minimally invasive image-guided procedures to diagnose and treat diseases in nearly every organ system. And there's not many doctors in the hospital that we don't talk to. Probably dermatology, and that's about it. Everybody else has something that we talk to them about. And I should say that this is no longer a subspecialty, it's actually a primary specialty, much in the way that radiation oncology used to be a subspecialty of radiology, but then became its own specialty. IR is now a primary specialty separate from radiology. So that may have implications in the future for how much you can cross over and do IR procedures as a general radiologist. But I will tell you, over the last 10 years, the most explosive growth in our specialty has been in the field of oncology. And that's sort of where this interventional oncology thing kind of comes in. Interventional oncology actually started about the same time as interventional radiology. The picture that you're seeing over there on the right, that's actually embolization of a vascular spine tumor. And this happened in 1965. This particular procedure happened in 1965. And published reports started trickling out in 66 through 68. And so, there was initial excitement by the radiologists because we could treat stuff that people didn't want to operate on because it was too morbid for the operation. But it kind of didn't go anywhere after that. Just in case you're wondering what they were embolizing back in the 60s, because we didn't have any of the fancy particles we have now, they were using macerated pig muscle that they were either dumping in a blender and then putting into a catheter to embolize, or they were using very small metal beads. Those were their fancy embolics back there in the 1960s. So at the time, it looked like maybe IR would become the fourth pillar of cancer care. You've got pathology, you've got surgical oncology, and you've got medical oncology. But there was a real problem with this back in the 1960s in that cancer is, the oncologists think cancer is a systemic disease and all we do is local stuff. So we're not helping them at all in terms of their beliefs. And then the surgeons felt like you can't cut it, you can't cure it. So we didn't help them. And the pathologists weren't even fans of us because at the time we weren't getting them tissue. And so basically, we kind of were having sort of problems in all three of these areas. And so that kind of led to IR kind of being booted out of the specialty of cancer care until the early 80s, which is when we sort of kind of had the beginnings of what is now very robust role in cancer care. And that started with cirrhotics. And cirrhosis was a very interesting disease because these patients were too sick for surgery, but they still wanted treatment, but they wouldn't survive the surgery. Only 7% of candidates at the time were resection candidates. And there were no oncologic therapies for these patients. Until 2007, there were literally no chemos that showed any benefit against cirrhosis or against hepatocellular carcinoma. And the reason for that is that this is actually a cancer derived from the most complicated cell type in the body. And one of the major roles of the liver is to detoxify drugs. And so cancers got really good at pumping drugs out and detoxifying drugs to the point that, they're resistant to most chemos. And so this was not a very effective strategy. And so there wasn't anything else to do for these people except potentially treat them via interventional radiology. And, this is about the time prior to us doing any kinds of treatments on the liver, they tried transplanting some of these patients with limited cancer and it worked and the patients survived and they didn't recur because HCC is a little bit different from most cancers in that it actually stays in the liver 75% of the time. So most of the patients who die with HCC, 75% of them, it's confined to the liver and only 25% does it get out of the liver. And so that was kind of an ideal candidate for this local regional therapy business. Plus, it preserved patients on the list so they could get transplants. So the current numbers for HCC, there's 26,000 individual cases per year. Again, at this point in history, about 1 in 15 are candidates for surgical therapy. No medical treatment till 2007. 85 to 90% have cirrhosis, so they have limited hepatic reserve. So even if you could do chemo, their liver might not tolerate the chemo. The portal vein. And even in terms of oxygenation, the portal vein is richly oxygenated blood. 75% of the total flow to your liver is portal vein, 25% is hepatic artery, and 70% of your total oxygen to the liver is coming from the portal vein when you're in a fasted state, and 40% when you're in a postprandial state. So if you have these cancers which rely completely on the hepatic artery, whereas the rest of the parenchyma is getting most of its oxygen from the portal vein, that allowed you to sort of have a differential that you could manipulate by going into the artery and embolizing these tumors. So, when we originally started out, the paradigm was there were the oncologists who were poisoning the patients, the surgeons who look like this, primarily operating, so to speak, on the patients. But now there was a new specialty sort of in the middle of these two that could actually help out with both of these. And that was kind of the interventional radiology, interventional oncology people. And that's kind of grown significantly since those early case reports. So if you look back in 1967 at the procedures that we performed, not a whole lot of stuff here. Although the most terrifying of these is actually the image-guided in utero fetus infusions for RH mismatched babies. I'm not sure I'd want to do that nowadays, but apparently they did that back in the 1960s. But nowadays, there's an incredible amount of different procedures that we do in interventional radiology, and there's enough procedures that you can actually spend most of your career completely specialized in just one sort of subsegment of interventional radiology. There's people who just do vascular. There's people who just do oncology. There's people who just do pain. And so the specialty is so huge at this point, we actually have twice as many procedure codes as any other specialty in medicine. I don't know if you knew that, but it's actually true that we have twice as many procedural codes as the next specialty behind us. That can get confusing, but it's actually sort of easily divided into basically three areas that we primarily do. There's embolization, there's ablation, and there's diagnosis. Those are, for oncology, those are the three areas that we primarily are working on. Now, you could also argue, okay, we do pain, we also, which is peripherally related to oncology, and you could talk about biliary drainage, which allows people to get chemo, but primarily these are the three areas that we do in oncology. Otherwise, we'd be here all night for me telling you all the stuff we do. And when you talk about embolization, you're talking about bland embolization, chemoembolization, and radioembolization, which you do in different circumstances, sometimes in order to directly treat the tumor, sometimes to allow the tumor to be treated. For instance, I have, next Monday, I'm doing a procedure where I'm embolizing spine met from renal cell carcinoma, because those are incredibly vascular tumors, in order to allow the surgeon to be able to safely resect the tumor after I embolize it. So we do this, and sometimes we even do this in the context of tumors like in the duodenum that are bleeding into the bowel to kind of palliate the patient in terms of preventing their bleeding. Same thing with uterine malignancies that bleed. And so we do a lot of this bland embolization, chemoembolization, and radioembolization, which is small particles loaded with radiation in order to treat tumors and palliate patients. In the field of ablation, there's a lot of different kinds of ways that we can ablate things. We can do radio frequency ablation, which is using electricity and resistance, cryoablation, which is freezing things, microwave ablation, which is exactly what it sounds like. I have a probe that has a microwave that, like on the end of your counter at the end of a needle, and I can cook stuff. Irreversible electrication, which is using electrical fields to depolarize cells to cause them to die, ethanol ablation, and then bone cement injection. Those are all methods of ablation. Bone cement, that may sound weird, but the bone cement actually heats up to 60 degrees centigrade, which is enough to be ablative for a lot of these tumors. So it actually does kill tumor when you put bone cement and stuff. And then for biopsy, we do biopsy, obviously. With the age of personalized medicine, this is becoming a larger and larger part of interventional radiology. We're biopsying things all over the body, and they're asking us to do crazier and crazier biopsies, because if they don't have the molecular data, then patients aren't candidates for certain treatments. And so this is becoming a really important part of what we do. And also, there's other things along this line that are developing over time. So, here's an example of a patient that I treated, 48, 5-year-old woman, no significant medical history. This is an HCC, biopsy proven. She does own a bar, so I don't know if it's like karma or something, but her AFP was 40,000. And so I did 2 second-week Y90 doses to her. And Y90 is a beta emitter, so it only treats exactly where I put the radiation, and it doesn't treat anything else. And I can give a dose that's significantly higher than what the radiation oncologist can give because of this sort of local effect. And actually, this is her, 6 months later, and you can see there's not anything left of this tumor. And actually, we went another 2 years on this lady, and they kept arguing about it, and they ended up transplanting her, and she did great, but they found no living tumor in this. So you took this enormous tumor in a patient clearly not a surgical candidate, and we cured it, with Y90. Now, probably she had something in her liver that made it prone to making cancer, so it's probably not a bad thing that she was transplanted, but they couldn't find any tumor in this when they actually did the frozen sections. And she still has no tumor 3 years later after that. What about this guy? This guy is a 45-year-old football coach with 5 kids who has neuroendocrine tumor and this huge neuroendocrine tumor at the dome of his liver. Now, we embolize these often because you only get symptomatic from neuroendocrine tumor when you have liver mets. But this particular lesion didn't respond. And so the question is, can we do anything to help him? Because he's getting diarrhea and flushing and shortness of breath from this tumor. And so what do I do about this? I'm not trying to cure him, but I'm trying to make his symptoms go away. And so what I did do is put 3 ablation probes into this thing. And you can see this is the CT scan. And I hydrodissected his liver away from the chest wall to make sure that I didn't do anything bad to any of the surrounding structures. And, that's immediately following the picture on the left is immediately following our ablation. And that's him 6 months later. And so you can see we completely killed that tumor. His symptoms went away and it's shrinking away. And so again, this is a patient with metastatic disease, not a surgical candidate, incredibly symptomatic from this tumor that we managed to give him back an asymptomatic interval. And I think he actually got PRRT after this. So he might actually be cured last I checked, but he went a long time without recurrence of his symptoms. PRRT is peptide receptor radiation therapy, by the way. So the crazy thing is when you look at both of those cases with a major surgical intervention, actually neither of those patients stayed in the hospital. They both went home the same day. And so that's the power of IR, is that we can operate on people who otherwise wouldn't be surgical candidates, but they also go home. They don't have to stay in the hospital. So patients who don't, aren't good candidates to stay in the hospital or don't want to stay in the hospital, I can treat them and send them home and they do just fine. So what are we going to do in the future? That's the big question that kind of comes up. And the answer is lots of stuff. So I'm sure all of you are hearing about immunotherapy all the time. The big 3 are actually Opdivo, Keytruda, and Yervoy, or nivolumab, pembrolizumab, and ipilimumab. And these kind of exploded onto the scene in 2014 when they were granted expedited approval because they took metastatic melanoma, which had a less than 5% 5-year survival for metastatic, stage 4 melanoma, and they gave it a 65% survival if you used a combination of ipilimumab and pembrolizumab. And nivolumab and pembrolizumab are PD-1 inhibitors, are programmed death ligand 1 inhibitors. And basically, tumors express this ligand, and what it does is it actually prevents the immune cells from attacking the tumor, because the anti-PD-1 actually says, oh, no, I'm self, leave me alone. And so they often massively overexpress this PD-1. And if you put a blocker on it, it actually prevents that from happening. And so you can resensitize the immune system to these tumor cells. And pembrolizumab and nivolumab are both exactly the same in terms of that sort of thing. They have similar spectrums of activity. They're approved for the same diseases. Ipilimumab is actually to CTLA-4, a cytotoxic T lymphocyte antibody 4. And that's another marker that actually, again, sensitizes the immune system. And the beautiful thing about these drugs is when people respond to them, they really respond to them. So not everybody responds to them. In fact, only about 20% of patients actually respond. But when people do respond, they really respond. And when they really respond, it's a response. And then the other thing about them is most of you realize, seeing patients in the hospital, that chemo sucks. chemo's really hard and it's unpleasant, and the vast majority of people have tons of side effects. So these actually don't have a lot in the way of side effects. Some people get diarrhea, some people get autoimmune sort of conditions, but the majority of patients actually tolerate these medicines very well with very minimal side effects. And so if you get a patient that responds to these can be incredibly powerful drugs. And azatolizumab is actually a PD-L1 inhibitor. So it's the opposite side of the PD-1, PD-L1. And it's actually approved for urothelial cancer, but similar idea. And, they're obviously working on multiple other markers, but we haven't really found anything that's a great marker besides PD-1, PD-L1, and CTLA-4 at this point. But multiple are actually in clinical trials. And the real power of this is one of patients who I treated with TACE, and her HCC sort of laughed at me. And you see she has all this tumor that's in her central abdomen. And if you look at this, her 6 weeks later after we put her on pembrolizumab, all that stuff was shrinking away. And she went 2 years with terrible cancer that shrank away and gave her back an asymptomatic interval. She went from ECOG 3, which means she was barely waking up to eat, to ECOG 0 and living her normal life for the next 2 years before she recurred and actually ended up passing. But this is the power of these kinds of drugs. But again, only 15 to 20% of patients respond at all. And so that's a problem, right? Because you'd love for all of them to respond, and 2 to 3% of all patients respond significantly. So you get benefit in patients, but not everybody. And so the question is, what we do to try to increase the number of patients who actually get good response to this. And this is an area that we're getting into. So there's, in addition to doing sort of directed injections using catheters, like when you have metastatic disease to the liver, instead of giving the nivolumab into the entire body, why not give it directly into the liver to try to sensitize the liver to actually attack those cells? And so that's one area. And then the other thing we're doing is something called intratumoral injection. And the first intratumoral drug was approved in 2016, again, or 2017, sorry. Again, for melanoma, but because melanoma is a really good target for all of these immunotherapies, but they're starting to scale this to other drugs. And there's actually 60 intratumoral injection drugs that are currently in clinical trials. And the thing is, if you have an immunotherapy that's too toxic to give systemically, like something that targets the intrinsic immune system, you can use by injecting it directly into the tumor. And sometimes it ramps up the immune system enough that it actually causes the rest of the body to attack the tumor everywhere. So you treat one tumor and it treats all the tumors because you sensitize the immune system and get a bunch of cells to actually differentiate into cells that can attack that tumor. And there's, again, 60 of these that are currently in clinical trials. I work on some of the clinical trials, especially the ones that are most common are toll-like receptor type drugs, but there's a lot of stuff that's going on in this. So again, in order to put the needle into these lesions and adequately inject them, that's going to require interventional radiologists. So this is something that we're doing, just starting to do, but is going to be a much larger part of our practice as time goes on in this field. And then, in the setting of metastatic disease, this is a gentleman who I treated last week. He's got this big lesion in his adrenal. He's got lung cancer. He's being treated with pembrolizumab, and he's doing great. He's had a 2-year disease-free interval, but then all of his tumor is staying the same or getting smaller, except this one lesion. And this one lesion is growing. And so what do you do about that? They tried to irradiate it. It didn't work. It continued to grow. And so how do you deal with that? And this is sort of a new thing that you're going to hear a lot about over the next couple of years. It's called oligoprogressive metastatic disease. And it's really only a thing when you're talking about immunotherapy. And what you have is a small subset of the tumor that's resistant to the immunotherapy because it stopped expressing whatever marker the immunotherapy is attacking. And so you don't really want to take them off the immunotherapy because all the other tumor is responding. And if you take them off, all that tumor will grow too. but you have one tumor that's growing out of control or two tumors that are growing out of control. And so this is an area that we're, again, getting engaged in to treat these patients. And basically what I did was put 3 cryoprobes into this adrenal gland and I froze it. So you can see, actually, these are my needles. There were actually 3 needles in there. And this is a big ice ball where that adrenal used to be. So I can't show you the follow-up picture because he hasn't come back yet, because I just did this last week. But this is an area that we're really getting into, especially in the setting of lung cancer, because we don't have good chemo options. And sarcomas is the other area. We don't have good chemo options for those. So if they respond to immunotherapy, great. But if one tumor sort of escapes the immunotherapy, then you can start playing sort of whack-a-mole using ablative modalities to try to continue to increase the length of their asymptomatic interval. And there's also devices that you can use to help you deliver, in this case, the Surefire. And this company actually has immune cells that they actually engineer in order to attack certain kinds of cancer. So they've engineered immune cells to attack any cell that has the CRC receptor. So that's obviously not good if you put that in the colon, because your colon will necrose and fall out, and that's poor form. But in somebody with metastatic colorectal cancer to the liver, you can put this catheter up into the hepatic artery, infuse these cells into the liver, and the only organ that will be treated is the liver, and you'll kill the metastatic disease from the colorectal cancer in the liver specifically. And so you can actually use these kinds of local therapies in the setting of metastatic disease to treat these patients. Irreversible electroporation is another thing that's sort of right on the cusp of being ready for prime time. You can see there's 3 needles in the head of the pancreas, and we went right through the stomach in this case, right? And basically, for patients who are not surgical candidates because the vessels are involved with pancreas cancer, we can actually still burn the things, even though, you'd think, oh, well, aren't you going to damage the vessels? And it turns out irreversible electroporation, where you actually kill all the cells using electrical gradients to eliminate their sodium-potassium gradient, it kills the cells but doesn't do anything to the basement membrane. And so as long as you anticoagulate these guys for a couple of days after you treat them, even though you're completely cooking the vessel grows back endothelium and does fine, because you don't get rid of any of the basement membrane. And so this is another modality that we'll probably end up doing a lot more, because we can operate on people who are not surgical candidates according to the surgeons. And so again, another area, and this was done percutaneously. This is done by my friend in Florida. I didn't do this. I'm trying to get the IRE box, but it's like $500,000. So we don't have one yet at MUSC. It's not 500, it's like $100,000. So we don't have one yet. But anyway, this is another modality that you can use to treat tumors in places that you would consider not accessible in the old days. You know what I mean? Because I'm not going to hurt the vein. I'm not going to hurt the splenic vein, which is right above where these needles are. And I'm not going to hurt the hepatic artery or the hepatic vein or the portal vein, even though I'm right in the area, and I'm going to kill the tumor. So it's actually a really neat area that we're kind of getting into. So I would say the future is bright for IO. We're going to do well. And, there are other people sort of getting into the space, not so much in IO. I don't know why, but like in vascular disease, obviously the vascular surgeons got heavily into that, once they realized we were going to replace them if they didn't. And, I'm sure at some point, some people will do some of this stuff. But a lot of this is very difficult angiography. And so we do have kind of unregulated control of the space at present. So I do think the future is bright, and you'll get to do lots of interesting stuff if you go into IO. And the future is more what you're worried about. When I started medical school and I went to follow around the interventional radiologists, they were doing all peripheral vascular work. They weren't doing much of this oncology stuff. And by the time I finished residency, oncology makes up 70% of the practice now. So this is the area that I think we're growing in the most. So it is something to be excited about from that standpoint. So with that, I'll take any questions if anybody has any.
Thank you, Dr. Johnson. I have a quick question. How do you control where the heat goes and like how much do you apply? Can you see it on the imaging that you're using when you do ablation?
Sometimes you can, sometimes you can't. It depends. So you basically know what the device is capable of if you're talking about like microwave and stuff. And actually, on microwave, you can follow with ultrasound usually because you can actually see the gas bubbles from the water vaporizing, and that correlates really, really well with how much ablation you get at the end. And so, yeah, so plus you have a basic idea of how big the cavity is going to be based on the specific device that you're using. For instance, if I'm using the Imprint, which is what we have here at MUSC, and you wanna use that, its maximum ablation size is about 4.5 centimeters, and so you'd have to use more if you want to burn something bigger. But you kind of have at 100 watts for 5 minutes, which is generally what I do. For cryoablation, you kind of have an idea how big the ice ball is because you know how much heat gets carried away by the body. It's sort of a balance between what's called convection and conduction. So you conduct the heat out in the tissue, and then the body carries away the heat or cold via the blood flow via convection. And so you know sort of how much of that it's carrying away. And so it's that's why you do have fellowships, you know how to do all that.
Oh, interesting. Thank you.
Yeah. Any other questions?
Johnson. So like with ipilimumab and a lot of those CTLA4 inhibitors and like the PDL or PD1 inhibitors, like how much so you say you treat patients with that, like are you just injecting them straight, or are you going straight into the organ each time? Like are the oncologists angry that you can do that, or are they okay with
it? No, so I'm actually not injecting those by and large. What I'm doing is combination therapies with those. So like, for instance, my oncologist in Colorado, when they wanted to treat somebody with HCC and they wanted to put them on nivolumab and they had HCC, they would always have me embolize them first because they thought that it killed cells and released antigen to make the nivolumab more effective. And so that's the kind of thing you're doing. And then I think in the future, probably we will be doing direct infusions into the liver because you can get a better target to off-target effect. Because again, the problem is the super low response rate. And so if you could increase that even by 5%, that would be a massive boon to patients because you'd save a lot of lives with a drug that doesn't have really bad side effects. And so currently we're not doing a lot of injection of ipi or nivolumab, ipilimumab, or pembrolizumab, but it is something that's coming down the pipe. People are doing research on that to see if you get better response rate if you directly infuse it into the liver. And they're fine with that. I mean, another example of kind of local treatment using chemotherapy, which I don't ever get yelled at by the oncologists because they participate in it too, is we actually have a double balloon catheter that we can put up next to a pancreas cancer, and we can infuse gemcitabine directly into a pancreas cancer and shrink it. And they get less side effects when we do it that way, and they get better response rates. And so that's one of the clinical trials we're involved in now. And it's not just me, it's actually the oncologist. Most oncologists are actually pretty easygoing about that sort of thing. You know, in private practice, it's a little different because they run the infusion clinics, and so they make money on the infusion clinics, so they might get crankier if I took away their infusions. But in academics, they don't care because the hospital gets that money. So, and the hospital doesn't care because it all goes to the same place. You know what I mean? They get their money regardless. And so it's not a huge deal in terms of that. But you're right. In private practice, it could end up being a problem in some clinics. But once there's level 1 evidence, oncologists are super responsive to that. They mostly want people to live. And so they're not at all angry that, you know, there are some interventional radiologists who actually prescribe sorafenib in conjunction with chemoembolization. And we can do that. We're qualified to do that as long as you're willing to deal with the side effects and get the calls when the patient's having hand and foot disease or bad diarrhea and stuff like that and admit them to the hospital. they're actually fine with that. So I've never run into an issue with them getting mad at me because I was giving the chemo. Yeah, they do make a lot of money off the immunotherapies. Does anybody know what it costs to be on immunotherapy for a year?
Isn't it like $300,000 or something like that?
500, $20,000 an infusion is what they currently cost. And so that's the other thing is we're cheap relative to a lot of this kind of stuff. Even if you look at Y90, which is relatively expensive, we're still cheap compared to any of those kinds of treatments. And so we do occupy space because also the companies like us, because we're way cheaper. Me doing an ablation of a right lobe liver lesion, that's an order of magnitude cheaper than a right hepatectomy, and a patient doesn't stay in the hospital for 7 days like they do for a right hepatectomy. And so eventually we're going to replace some of these more invasive modalities, and I think even the surgeons see that. I actually help the transplant surgeons sometimes do laparoscopic ablations because they even recognize that sometimes doing less invasive stuff is better. But yeah, any general questions about IR are okay too.
I have another question just about your lecture.
Yeah.
So like you talked about how like they can engineer those the killer cells for the cancer for colon cancer mets to the liver. How do they get them not to leave? I mean, like leukocytes can go into the blood vessels and leave and like go into the lymph nodes. And you said that like they don't leave and they never really go to the colon because it would necrose. So like, do you know how they do that?
Yes, I do actually, because I know the guy who invented the technique. So first of all, they get rid of some of the chemotactic signaling molecules that would cause them to leave, and especially lymphocytes. Most of them are not very long lived, and so if you stick to cytotoxic cells and phagocytic cells, they only have a half-life of a couple of days anyway. And usually the liver actually holds on to those cells pretty well, because the liver is actually your second largest site of, I have a PhD in this, sorry, but it's the second largest site of the reticuloendothelial system in the body. So you've got tons of Kupffer cells, you've got tons of dendritic cells, and what they hope is they put some of those cells in there, they attack those cells and actually sensitize the dendritic cells and the Kupffer cells, which don't leave, to these antigens as well. And so it only gets attacked in the liver. Now, is there some off-target effect? A little bit, but it's not bad. Actually, in their initial data, it's not bad because those cells don't really leave while they're attacking stuff. But you're right, they can move around, and that would be bad if it went to the colon. But if you infuse them on the hepatic artery side, it turns out they stick long enough that they generally die before they get to the colon.
Do you think in the future with a lot of this stuff, like they'll just move to the point where they can just kill enough to sensitize the body instead of just trying to get something that will completely wipe it out all in and of itself?
Well, that's what a lot of the intratumoral stuff is about, is sensitizing the body to those specific tumor antigens and getting the body to attack it all over by only treating one lesion. So yeah, I think that is the eventual goal, and I think they'll get there. When all these immuno-oncologic agents came out back in 2014, people were like, oh God, we're going to end up not having any cancer to treat. It's all going to be treated by immuno-oncologists and all the IR guys are going to be out of it. And that's not true, because the majority of cells, in fact, 80%, either get rid of the proteasome that actually is responsible for breaking down antigens, or they get rid of the MHC class 2 molecules that actually present the antigens. And if you don't present antigens, the body can't attack it. So I think that this is actually more of a growth potential for us as opposed to negative. Whereas a lot of people thought this was going to be a negative originally, we're going to end up doing a lot of whack-a-mole going around the body and killing these oligoprogressive metastatic lesions than anything we lost because they treated HCC with nivolumab. Do you know what I mean? Anything else?
Dr. Johnson,
You're awfully quiet over there.
What was your PhD in?
Liver physiology.
Interesting. Like having anything to do with cancer or with immunology, or not
It's
really?
actually mostly to do with liver signaling. So a little bit, but mostly to do with liver signaling. So I looked at signaling perturbations so my big paper was actually looking at the proteome of the mitochondria in the liver, and then also comparing metabolic effects of diabetes on the proteasome of the liver relative to non-diabetic animals. And so basically I looked at metabolism and what happens to metabolism when you're diabetic. And a lot of that is similar to cancer. So I thought I picked it specifically because I was trying to do something that was applicable to my future job as a interventional radiologist. So I know a lot about pathway metabolism as a result. And that actually makes me sound smart when I go to conferences and start talking about chemo and stuff.
If there's no other question, I had one more question. So I did my PhD in MRI. That's, well, I guess what I find interesting. And I went to this interventional radiology talk using MR last week. And I was kind of wondering what your opinion is on using MRI, if that's like in the future going to be more of a thing or not really.
So presently, it's something that people have been working on for a long time, because the beautiful thing about MRI is it's a strong magnetic field. And so if you have a catheter that has ferromagnetic elements in it, you could potentially steer it to wherever you want to go in the body using MRI. Mm-hmm. And people have been working on that for a while. It's not ready for prime time, but it is something that I think is in the future. And again, as we get more involved in these oligometastatic lesions, sometimes you can't see them on CT, especially in non-con CT. Sometimes you can't get there with ultrasound. And so we occasionally do things MR guided. And I think as devices get better and as more things get developed, I think that it may be more prevalent. One of the things that I think specifically applies to MR is there's a device called the Visualase, which is a laser ablation probe that's MR compatible. And so what you can do is you can actually put it in your lesion in MR, and then you can actually track the heat map in the lesion while you're cooking it. So you can actually look at your heat map, and you can tell if you've adequately treated the tumor or not based on that. Now, right now, they primarily use that in the brain for ablating patients with Parkinson's disease, but it's been used in the prostate, it's been used in the liver, and it was pretty successful in those sites. And so I do think that that's kind of coming. It's just we're slower to develop good devices for MR than we are for use in CT and ultrasound.
And does that have to do just with the complication of it being in a big magnet and the accessibility? Or
accessibility is definitely a thing, because getting it into the magnet, sometimes it's hard. The lab that I did my PhD in actually did a lot of MR guided intervention stuff, particularly in the heart, but and some other stuff too. But and basically it's really, really hard to get your devices in because the gantry is so small. And so developing better MRs that don't end up, so the problem is the bigger the gantry you make, the more field homogeneity you get, right? And so they make the hole small because otherwise if you make it big, you get a crappy magnet. And so getting devices in there is hard in that context. But I think they're going to get better at the physics of creating MRI with wider bores. And I think that will be simplified. And then developing devices that have zero ferromagnetic elements and are also not conductive of electricity. Because the problem is, if you put a really powerful magnet up against something that can conduct electricity, sometimes what you generate is electricity, right? So that's the way you generate electricity, is using a magnet next to a conducting coil. And so sometimes you could potentially electrocute a patient if you put the wrong device in just because it's up against the gantry of the magnet, a superconducting 1.5 Tesla magnet. And for those of you who don't know magnets, the magnet that they use to pick up cars in the junkyard when they're tossing cars on piles to like crush them, the magnet they use is a 0.24 Tesla magnet. And so the magnet that you're putting patients into is a 1.5 Tesla or a 3 Tesla magnet. Okay. So, and for those of you who worked in a lab like mine who have fancy magnets, the magnet that you need to be able to pick up an animal by the iron in its body is a 7 Tesla magnet. So we would pick up mice in the 7 Tesla magnet without touching them, just by using the iron that's in their body. So to give you an idea of the strength of the magnets that we're using to do this kind of stuff, it gets very complicated trying to develop a magnet that can actually be wide enough bore without having complications of the devices. And that's why the Visualase actually uses like fiber optics. And so that's how you can use a laser probe that's all plastic, right? So you don't have to have any metal in that device in order for it to work, because it can all be fiber optic.
That's really cool. I guess there's several human 7Ts too. It gives you really bad vertigo when you go in there.
Yeah. Oh yeah. Yeah, I've been in the 7T. There's a human 7T, and yeah, you get terrible vertigo when you're going in or out. Once you stop moving, it's okay. But when you're going in or out of them, because I volunteered for studies because I was a former med student and I needed to eat. And so I volunteered for all kinds of studies. And yeah, it feels terrible going in or out of it. Because I think it affects your inner ear somehow when you're going in or out. It messes with the crystals in your inner ear because they have some ferromagnetic elements, and so you feel like you're going to throw up when they're moving you inside the magnet.
I like MRI though. It's really cool. I think
Yeah.
it's, be able to give you a bunch of different contrasts maybe while you do procedures, if we can figure out how to work with it. But
yes.
I have another question for you, Dr. Johnson. So like with these, I just forget the phrase they use, oligio, whatever, when you're
oligo-progressive metastatic disease.
Oligo-progressive metastatic disease. So like, early on, has there been any correlation that they've found with like where things met to, whether they lose their antigens, or like what type of correlations they see on like what survives?
No, because it's all sort of randomly as to which particular cell escapes immune suppression. And so, for lung cancer, it's the place you tend to see these oligoprogressive mets where lung cancer goes, which is the liver, which is the adrenal, you know what I mean? And so those are the normal sites. I've ablated people in their lungs who, were metastatic lung cancer bilaterally. One lesion starts growing on one side, and I ablate that. So it's either going to be lung, adrenal, or kidney, or liver, or bone for lung cancer. And then for breast cancer, it's going to be bone or liver. You know what I mean? Because that's where they go. And so it just depends on the cancer, what its natural distribution. I haven't seen anything to this point on like, okay, adrenal mets are more likely to gain immune escape than, intraparenchymal lung mets. You know what I mean? So I haven't seen anything on that, but it's easy to follow because you get a PET scan and one thing is growing and nothing else is growing. And that's when they call me and say, hey, can you help me? And it's becoming a thing. I mean, one of my friends who's an IO doc at UPenn, 80% of his practice is now treating oligoprogressive metastatic disease. Doing ablations.
When you talked about like kyphoplasty and injecting the bone cement and how hot it is, are you usually using that for bone mets from other cancer?
Yes. What I do for bone, because I do actually a ton of that actually in our practice. I do a ton of kyphoplasty for bone mets in particular, more often than benign fractures. I do benign fractures too, but mostly bone mets. And basically what I do is I put the needles in just like I would for the kyphoplasty. Then through that, I put a radiofrequency ablation probe and I cook the vertebral body first. And then I put the balloons in to open up a space in the vertebral body for my cement. And then I put the cement in. And so you do that all through the same needles. And you can get a biopsy at the same time too. So it's actually kind of nice. You biopsy, you ablate, and you do kyphoplasty all at the same time. And for the mets that are sort of confined to the vertebral body, you can get pretty good results for those in terms of both ablation as well as relief of pain. Their pain relief is almost instantaneous, actually. And, I do mostly IO, but I also focus on pain. And in this particular center, pain is kind of undertreated. And so I tend to do a ton of pain here too.
Do you know the history of why IRs tend to, like, they took kind of kyphoplasty away from the orthopedics? Because we just got out of our bone block and the orthopedic surgeon's like, oh, we don't really do those anymore. IR does all of them. Like, is it because y'all started using them a lot more to treat cancer and bone mets, or?
So there's a couple of reasons. One, I'm no shade thrown at all at my ortho colleagues, but we're better at x-ray than they are. So the imaging is easier for us than it is for them. And we have better imaging equipment than they do. So that means I can do ones that they can't see. And then the other thing is about 10 years ago, they cut the reimbursement of kyphoplasty. So back then it paid so much money that the orthos and neurosurgeons were all about it. But then once IRs demonstrated that they could do it and do it quickly, because we're a little bit faster too, just because we're used to kind of cooking, the Medicare cut the reimbursement by 20 or 30%. And so it became less attractive to them in terms of reimbursement. Still pays pretty well, to be perfectly honest. It became less attractive to them. And the thing is, it's like when you do image guided stuff all day long, you get really good at looking at a screen and moving your hands at the same time. Whereas for the orthos, they do that sometimes, and then other times they do, open surgeries, and, repetition is the most important thing to develop expertise. And when you're constantly looking at imaging, you're just better at seeing subtle stuff. It's not because you're a better doctor. It's just you're better at seeing it because you do it all the time. There's no ortho alive that does, 50 image guided procedures a year. I do over 1,000 every year. You know what I mean? And so it's just not feasible for them to be as good at the imaging as we are.
Gotcha.
And here, actually, they tended to be pretty. So before I came, I do a lot of kyphoplasty. I'm doing 5 this week, actually. But, before I came, the entire institution was only doing 6 per year because they're not as aggressive as we are either, especially doing high thoracics. I'm doing a cervical kypho, which I don't think they would touch with a 10-foot pole. So there is an element of being good at being aggressive and knowing when you can be aggressive and when you can't. And that's done by repetitions. You know what I mean?
Yeah. So I don't know, we only got 5 more minutes, but so with most of the kyphos that you do, you said that you do some of them that are just benign fractures. Like, do you find that it actually helps support their vertebrae? Because I'm pretty sure, like, when one of the orthopedics came, it was like the evidence is kind of shaky on whether it actually like does what it like works well for support and like I guess like actual like mechanical forces, whereas like are you just using it mostly as an ablative therapy?
So there's a couple of things. One is that it actually fixes the fracture in that vertebral body. So compression fractures are unstable fractures because anytime you move your spine. And so those patients have a hard time moving around. In particular, they have a hard time sleeping, and they have a hard time transitioning from laying down to sitting up and sitting up to standing. And so because all of those require extra support from your back. And so the things that kypho is good at is it corrects the Cobb angle because you do increase the height of the vertebral body. So you don't get as many hunchback old ladies. You know what I'm saying? Because you correct that. And sometimes when your Cobb angle gets off enough, your head's so far forward that you have constant back pain, not because of the fracture, but because you're straining the muscles to try to keep yourself upright because you're so far ahead of your hips. And so it helps with that. It shifts you back closer to natural. It does decrease your risk of subsequent fracture, but not by much. So it doesn't, for other levels besides the level that you're fixing, it doesn't make your risk worse, but it doesn't actually help it all that much because the real problem in those patients is actually osteoporosis. And so what you got to do, if you're a good doctor, is be very aggressive in making sure that the patients are getting treated for their osteoporosis. But kyphoplasties save people's lives. You don't want to be managed in a person who is a candidate for a kyphoplasty, you do not want to be, if your grandma breaks her back, make sure that she goes to somebody who's going to do a kyphoplasty and not manage her conservatively, as long as they, check to make sure all the things are safe. The posterior longitudinal ligament is intact and blah, blah, blah. But basically, conservative management of those patients is not good. There's really strong, there were a couple of New England Journal of Medicine papers from 2007 that said, oh, kyphoplasty is not good. And it's because one, it was one patient short of being clinically significant, the benefit. And in the other one, the negative control, they actually injected bupivacaine on the pedicles, which is a dorsal sacral, or is a dorsal nerve root block, which is actually helpful for people with fractures. And anybody who wanted to could cross over to the kyphoplasty. So all of the most severe pain patients crossed to the kyphoplasty group. And so it was a really poorly controlled study, but it was New England Journal of Medicine and JAMA, they like to publish really contrary articles. And so they published it. And so it kind of made it controversial for a while. But there's actually an AJNR study from 2019, December, which actually showed that the number needed to treat to save a life with kyphoplasty is 14. So if you treat 14 people with kyphoplasty, one of them will be alive, wouldn't otherwise have been alive at the end of the year. And by the time you get to 5 years, it's actually 11. And if you look at cost, it's actually cost positive. It costs less to do the kyphoplasty over time because people don't seek as much medical care when they get their fractures fixed. They're not constantly going to their doctors and getting back braces and going to see their doctor again. And the reason that you save people's lives is because people with fractured backs, they lay in bed and they don't get up because they're hurting, and they get DVTs and they get pneumonias and they get PEs, and their bones get softer because they're not moving around. And so they end up with more fractures. And so it ends up being kind of a vicious cycle, which results in some of them dying. And so conservative management of kyphoplasties in patients who are candidates for kyphoplasty is a terrible idea based on current available data. There's 27 studies, prospective randomized, that evaluated kyphoplasty. 25 show that it works. 2 said it might not work. So make your own judgment based on that. And there is a meta-analysis of all of those studies, and that one actually also strongly showed that it worked. And the fact that you save people's lives, it's a terrible idea to manage those conservatively. So I'm very aggressive doing kyphoplasties. This institution was not before I got here. They did 6 a year is how many this whole institution. And there were 3 different services that did it, not IR, because that wasn't one part of their practice here before I came. But it was actually neurointerventional radiology, ortho, and neurosurge were the only people who did kyphos, and they each did about 2 a year. And so you can kind of guess, when you only do that number, it's hard to develop expertise, right? Because you don't get enough repetitions to actually get better at it. And so it's kind of a self-fulfilling prophecy in that way. And so this is something that we're, doing more now, obviously. The neurosurgeons are the ones who are referring me these kyphoplasties. So it is something we do more now, but I think it's something that's still underserved in South Carolina in particular. Only 3% of patients with a diagnosis of acute compression fracture are offered kyphoplasty, which makes me sad. So there you go. Sorry, I know a lot about kyphoplasty.
Well, thank you so much, Dr. Johnson.
Yeah, no problem. And if any of you have any questions, feel free to email, feel free to come by and meet if you have questions about IR, if you have questions about other things. My email is johnthor@musc.edu. So feel free to, and I'll put it in chat too, just in case you want it. I'm happy to talk to you about IR in general, about career pathways, all kinds of stuff like that. So just let me know if there's anything else you need, okay?
Well, we really appreciate you coming, and thank you again.
No problem. Have a good day.